Today we will review a few important aspects of Down syndrome. As you can see here, an adorable baby with Down syndrome. We often have antenatal testing to look at the risks of trisomy. So I've made many videos on that, and I'll put the reference link in the video info. And obviously trisomy 21 screening is the most important one because of the incidence being 1 in 600 to 1 in 800. And the incidence increases as a mother's age increases. So above 35 years, the risk starts going up, and the age-related risk has to be considered as well. And it's a good idea to offer a test like NIPT as a mother's age starts going up, in addition to the first trimester or the quadruple test screenings later on. You can review the links that I share for the details on these antenatal testing. But once the baby is born, we suspect Down syndrome based on the clinical features. So as you can see, this is a baby with some striking features which you might have noticed in your relatives or friends. As a child grows, this is an adult with Down syndrome. You might have seen them working in supermarkets or even in the police force or other roles. They need supervision, but obviously they function as independent adults. And this is a child going to school. So the community-wide changes have happened, and Down syndrome children are incorporated into the general population quite well. So they go to regular schools, they start going for jobs, they may get their salaries. Of course, their performance is going to be lower because one of the key factors with Down syndrome or trisomy 21 is their IQ levels are lower. So we have the severe ones affected with the IQ range of below 35, but most of the children with Down syndrome have moderate learning difficulty, IQ of 60 to 70. And if they come in that range, they are likely to lead a fairly normal life with support from adults. So they are not street smart, they may need guidance, but they can do their day-to-day living. So when I speak to parents with Down syndrome, one of the analogies I use is that the Down syndrome children grow up as children. So they may not mature as adults, they continue to stay childlike. But they are generally very pleasant, very loving. They enjoy music, they enjoy dance, and obviously they enjoy eating. So there is a risk of obesity as they grow up as well. In terms of physical features, obviously, you have the typical features. We call it the epicanthic folds, the fold in the eyes. And we have the wide set eyes, the slanting medial slant, we call it the inner slant towards the nose of the eyes. Prominent tongue is a very important feature which is seen in quite a few babies. The face is square shaped and the back of the head is flat. So we call it brachycephaly. In the eyes, you may notice the brush wheel spots, which are these white spots in the iris, which is not often seen. And the wide sandal gap or the wide separation of the toes, the single palm mark crease, the middle crease is single, not double. And you may have the bent little finger called clinodactyly as well. The tongue may be furrowed. Obviously, this is more seen in adults, not in the babies. So when you look at the genetics, obviously, what you find depending on whether it is a translocation or it's a full trisomy. So you can see the trisomy 3 chromosomes of the 21, or you may get a 21-22 translocation or a 12-21. So according to what the genetic finding is. And the mosaic type is where some of the cell types are affected, some are not affected, and some of the mosaic chromosomal types are milder. But the mosaic type of Down syndrome only contributes to 3 to 5%. Majority are non-disjunction type with the additional extra chromosome. If there is a translocation in the family and one of the parents is a carrier of the balanced translocation, the recurrence risk is high. So in addition to the age-related risk, if the mother is having a child with Down syndrome, the risk of further Down syndrome in the family increases. If there is no chromosomal translocation, then the risk is say 2 to 3%. But if there is a translocation, then the risk goes up. So this is a summary of the facial features. So I'm not going to repeat it because most of you are familiar with that. There is a specific growth chart for children with Down syndrome. They tend to grow a little slower in the first few months because of their feeding difficulties, but then they start growing bigger with the weight. The height growth potential is lower compared to the other children. So it's better to plot them on the specific charts, but if you plot them on the regular charts, be aware that we need to adjust for these parameters. You can get this online if you have a child with Down syndrome. And in terms of the testing, obviously, in addition to the physical features, we also look at associated abnormalities. So we have a higher risk of gut abnormalities, obstruction in the gut, Hertzsprung disease where there is delayed stooling and there is a rectal problem. The mucous membrane or the muscle innervation is not complete, and we have associated cardiac anomalies in 30 to 40% of the children. In Down syndrome, if this heart disease is present, there is a higher chance of lung vascular disease as well, and some of them need surgery earlier than you would otherwise, so they need close monitoring. Higher chance of thyroid function concern. So in addition to the newborn screen, after 1 week or so, we do the free T4 and TSH to make sure that we are not missing hypothyroidism. And when the child grows up as well, we monitor the thyroid function annually. The blood count is done initially as well as annually in the initial years, as there is a higher chance of hematological abnormalities. There is a 1% risk of leukemia as the child grows up as well. And we need the hearing screen to be done formally and at follow-up as well. The orthopedic review is an additional factor because there is a chance of a hip dislocation in 6% of these babies, and the cervical spine subluxation risk is higher. So later when they grow up, we discourage contact sports and they may need a specific orthopedic review if there are any concerns. For the ENT, obviously, we continue to monitor them because of the shape of the airway and the relative reduction in tone. They are a little bit floppy. There is a higher chance of obstructive sleep apnea as well. And due to the same reason, the adenoid hypertrophy as well as a tonsillar enlargement may predispose them to middle ear blockage and hearing concerns. So they may need ENT review, grommet insertion as they grow up. So we have the 3-month review for the eyes, mainly to rule out an evolving cataract. This is looked at in the red reflex in the newborn period, but it's better to get a formal review with the eye doctor around 3 to 6 months. And the repeat full blood count can be done, and the hearing screen, we confirm it's normal and the baby is responding. At 6 months, again, if the eye review is not done earlier, you can do it. The same with the hearing test, you don't need to repeat it at that stage. The full blood count and thyroid function can be repeated, but in my practice, I don't repeat it at 6 months. I do it at 1 year again, as mentioned here. Early dental review is important. There is a high risk of caries, and hearing test and review for otitis media is important. And we continue to monitor the hearing, the ophthalmology review, dental review. Celiac serology, it's population specific, so the Caucasian population has a higher risk of celiac disease. Risk of diabetes after 5 years as well, so consider doing the HbA1c every 1 to 2 years if that's covered in the insurance, at least a fasting blood sugar to detect that. The thyroid function dental review annually can be done as well. So the blood count, thyroid function, glucose can be monitored annually. Orthopedic review in the beginning for hip dislocation and subsequently according to the risk of neck atlantaxial stability risk at 3 to 5 years or if symptomatic. Obviously, our aim is to incorporate them into the general functioning like a normal child and encourage the parents. So careful counseling is important. There are support groups for Down syndrome, and the schools often have support systems in place because essentially they will attend the normal school, they will keep getting promoted, but the response is going to be poorer. So I hope this helps.